This conference will now be recorded.
Is everybody ready for your test?
Yes, we can do that before we start recording this thing.
This conference will now be
Session
recorded.
is recording.
Oh, where's the clicker? It might be out there on the table.
When Garrett gets it. Come on in, sir. I just eat somewhere.
Oh, I have your thing. You see my arts and crafts that I did today? Thanks.
Oh, dope for pneumo? Dope.
I don't think it'll work for pneumo. I don't have a
It'll
hole
work
poked
for
in it
the
yet.
diaphragm.
But just like showing them. I want to make one for
All right.
pneumo, but I didn't have a balloon big enough.
Oh, I guess.
Maybe.
How'd everybody do on their test?
We had a one-way valve, maybe.
Huh? That test was fun.
Yeah.
So, did that test show you the importance of needing to know how your medications work? Yeah. So I'm big on that, right? Everybody here is going to be big on it. Mike's going to be huge on it. If you ride with Katie, she's going to be big on it. Like I've said, if you have a medication that you're able to give and you want to give it, you need to know why you're giving it, how it works, and how much you're giving. And if you don't know, now you know. And this test was the one to kind of show you what you did and didn't know. Yep. So we're going to go over respiratory stuff today. It's going to be a grand old time. Miss Becca went and spent hundreds and hundreds of dollars at Dollar General today, making a little thing for y'all. So
yeah, it was like probably $6 total, and a shit ton of balloons.
I'm going to put in for reimbursement, so it's at least $300.
Yeah, like I was driving through, and then afterwards my brakes were like, and I was like, it's fine though. We got a Subaru.
Yeah.
Yeah, basically. Yeah, it works. All right, so respiratory emergencies. The first part of this should be a lot of review because we just did respiratory and airway physiology, pathophysiology, all that fun stuff. So review the anatomy and physiology of the respiratory system. We're going to learn the different types of disease process that can affect or alter breathing, how they work, how you treat them, and then we're going to review medications. Which medication do we give for difficulty breathing? An inhaler. What kind of medicine's in the inhaler? Albuterol. Good. Okay. So this right here is a model of this.
We got to show the beautiful folks of Austin. Don't forget.
Yeah. Model. All right. So this yellow balloon is our diaphragm, right? So whenever we take a breath in, this diaphragm comes down, and then you watch the lungs, and they inflate, right? So this is what kind of ventilation. Is it positive or negative pressure? Negative, right? So whenever I'm bagging somebody, what kind of pressure is that? Positive. Okay, I'm going to pass this around if y'all want to look at it. Don't put your mouth on it. I mean, unless you're into that, but. All right, so diaphragm comes down. Breath comes in, diaphragm relaxes, and then the air comes back out, okay? So whenever we start talking about like pneumothoraxes and things, we'll kind of show you how that looks on the inside here. Also, we got lungs, right, for Saturday?
We have lungs for Saturday.
We
have
got
cow
lungs for Saturday. So we're going to bring them in. We're going to set them up so you guys can like see the alveoli expand and all that.
Y'all can thank our wonderful director, Mr. Michael Harris, for that.
Yeah.
He did. Y'all should have seen him out there. He had a lasso and a sword. It was great. Oh, wait, no, never mind. That was when he was chasing the pig through town.
All right. So inspiration is an active process. the muscle contraction, it increases the size of our chest cavity. So you can kind of do that on yourself. You take a deep breath in, your chest gets bigger. You breathe out, it gets smaller, right? Opposite, expiration, passive process. We relax and that air comes back out, right? So adequate breathing is we are breathing adequately enough to support life. So we have three kinds of respiratory distress, respiratory failure, respiratory arrest, right? Does everybody remember the three and how they each fit into how your patient would fit into each of the categories? Any questions on that stuff?
What is the difference between respiratory distress and respiratory failure?
Mental status. Good job. All right, so anytime you're assessing the breathing of your patient, we're going to look for rate, rhythm, and quality, right? So how fast are they breathing? Are they breathing fast or are they breathing slow? Are they taking shallow breaths? Are they taking adequate breaths? Are they taking huge, deep breaths? So those are things all to look out for. And then we're going to look at the rhythm. Is it regular or irregular? So whenever we start looking at irregular breathing rhythms, that's where we get into like our strokes or our head trauma. You're going to see an irregular rhythm, okay? I do want to talk about, I think I may have brought this up, but whenever you're listening to lung sounds, the most effective way with your stethoscope is what? Did I already talk to you guys about this? So stethoscope to skin, okay? So go up under their clothes. And then if you have them take breaths with their mouths open, you're going to be able to hear their lung sounds a lot better. And the best place to actually listen for lung sounds is on somebody's back. So if they're laying down and they can't really sit up for whatever reason, you can still listen up here, but it's going to be easier to listen on the back. So if they can like sit up and you go up under their shirt with this, that's going to be the most ideal way to listen to lung sounds. While you guys are doing your rides, try to listen to lung sounds on everybody. Okay, even if you get looked at funny, just listen to lung sounds. So inadequate breathing, that breathing is not sufficient to support life. So they're breathing way too fast, if they're breathing way too shallow, if they're not breathing at all, if they're breathing less than 8 times a minute, that's usually a problem, right? What's our normal respiratory rate for an adult? 12 to 20. Good job. So other signs you might see, inability to speak. We also get like this 2 to 3 word, it's called 2 to 3 word dyspnea. So what happens is they're having such a hard time breathing that they can only get like 1 or 2 words out at a time. So that is indicative that you should probably step in and do something, right? What is adventitious lung sounds? What does that word mean? Yeah, so any kind of irregular lung sounds. If it's not clear and equal, then you're hearing funky little trumpets in there or whatever you're hearing, that's adventitious. So listening to lung sounds, hear some abnormal breath sounds.
Stridor, a harsh, high-pitched sound heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. Rhonchi is a rattling sound heard in the larger airways caused by excessive mucus. Rales are a bubbling sound heard in the smaller airways, typically when they fill with fluid, commonly encountered with CHF and pulmonary edema.
So rales and crackles mean the same thing. So rales, crackles, that's fluid in your lungs. If you have long hair and you take it and you rub it between your fingers right next to your ear, that's what crackles sounds like whenever you're listening on someone's chest. Like that really fine, almost bubbly sound like Rice Krispies. If you don't have long hair, I'm sorry, but that's like the best that I got for you. So whenever we're talking about pediatric airways, remember that their airway is a lot smaller, right? So any kind of obstruction is going to cause more, it's easier for it to cause a problem in children. Also, whenever you're going to open a pediatric airway, keep in mind that we don't want to crank back on that head because their airways are so small that they're a lot easier to clamp off, right? Their trachea is more flexible, so that is another thing. When you're opening that airway, it's going to be easier. And then the cricoid cartilage, so we have cartilage right in here, and you can feel it on yourself. Men, it's the Adam's apple, like that kind of area right there. And yours is nice and like firm because you're grown, you're an adult. But kids, they don't have that as developed as we do. So some signs and symptoms or signs to look for in the pediatric community. Whenever we're looking at difficulty breathing, you're going to see like a nasal flaring. Every time they take a breath, their nares are going to flare out. They're going to get intercostal retractions like an adult would. So anytime you're assessing a kid for any kind of respiratory problem, you need to take their clothes off and actually look at them, because that's going to give you the best like sight that you can see. And then seesaw breathing. What is this seesaw breathing? Yeah. Yeah, so back and forth between the stomach and lungs, because they're so dependent on that diaphragm whenever they take a breath. Whenever they start struggling, you'll see it actually looks like a little seesaw going back and forth. Another thing is grunting. If you ever walk in and the kid's trying to take a breath and you're hearing like that's a problem. Like your little butthole should be like, ring, because that's scary. I think this is more pediatric signs. Let me see. Yeah.
Welcome back. I am Dr.
This guy
Manish.
says things
I
funny.
am going to show you 14-year-old male child who presented with complaints of cough, cold, and fever for last 7 days. Diagnosis is severe bronchopneumonia. In this patient, we will first see the case and then we will try to identify signs of respiratory distress.
Respiratory.
Have a look at chest of this child and you can see intercostal retractions quite prominent. Suprasternal retractions are also nicely visible. Now look at the face of the child to see flaring of LNSI, and the child looks severely distressed. Now let's see next case of cyanotic congenital heart disease, which presented with difficulty in breathing. This 2.5-month-old male child was brought by his parents. Note subcostal retractions, which are very severe in this child. Also note movement of head during respiration. I mean to say breathing.
I mean, honestly, the film is great.
Have a look at
The film's
another
great,
case
but
of
he's hard to hear.
bronchopneumonia and note severe respiratory distress in this child. Note the movement of neck while breathing.
I'm not saying he's wrong, but if you walk in and see a kid doing that, don't film them. Do something about it.
Yeah.
All right.
Mhm.
I like the video, but
I think
yeah.
it shows a good
Hold on.
example, though.
I just want to take some pictures.
Yeah, hold on a second. Yeah, that's a bad idea. Yeah, so on that first video too, you can see right in this area, it's starting to tug down, that tracheal tugging. So they're trying so hard to take that breath in, but their body's just tired, right? For whatever reason. So anytime you are delivering a breath, so we have our BVM out, we're giving our patient that's breathing horribly ventilations, right? So we know it's adequate by looking at chest rise and fall, right? Their SpO2 hopefully starts to go up as it should. You should see no distension in their stomach or very limited. So it's really hard to avoid distension completely. But if their stomach's getting huge, you should probably reevaluate how you're ventilating, right? We want to do 10 to 12 breaths a minute in adults. So one breath every 5 to 6 seconds, right? And then for kids, one breath every 2 to 3 seconds. So 12 to 20. In adults, if you're bagging somebody and their oxygen's not coming up and you see their heart rate start to come down, you need to reevaluate how you're positioning their head, whatever adjunct you have in, make sure it's the correctly sized one. If you start hearing any kind of adventitious sounds, reevaluate and then treat it, right? So if you start hearing gurgling while you're bagging somebody, what should you do? Suction, yeah. All right, so what is this position called? If you walk in and someone, good, tripod. So kids do this too, but it's really common in adults. So they're trying to get that weight off of their chest. So they're leaning forward, they're trying to take a deep breath in. Usually this is over a freezer, but they like to do it over a freezer too for some reason. I don't know. So their amount of distress felt may or may not reflect actual severity of the condition. So sometimes they're like, you know what, I'm just having a little trouble breathing. And you walk in and they're kind of breathing heavy, but their pulse ox is like 72. Or you might have the complete opposite where you get like the really anxious people that, you know, they kind of feel like they can't breathe and then they just like blow it out of proportion, right? Which for them, it's very real, right? They're feeling all that stuff. So keep that in mind. Make sure you're doing a good assessment of your patients. Whenever you're assessing difficulty breathing, we're going to go through our OPQRST. So who wants to tell me what the O stands for? Go ahead. Okay, what about P? Go ahead. Provocation. Q, go ahead for Q. Quality. Okay, R. Anybody else? Go ahead. Radiating. S. Severity. And T. Time. Okay, good. So we're going to start by observing them, right? So you walk in, that initial assessment starts as soon as you lay eyes on the patient. Well, it can actually start before that, but let's just say. So their mental status, are they tracking you whenever you walk in? Are they able to answer questions? Even if it is 2 to 3 word dyspnea, are they still able to answer questions? Are they alert talking to you? Some unusual anatomy that we'll see with like chronic COPD is this barrel chest. So we used to teach pink puffers and blue bloaters. And when I Googled it to Google a picture to put on here, Google said, we don't use these terms anymore because they offend people, which is so silly because I wouldn't call someone like a pink puffer to their face, but it's good whenever you're learning about it. So your pink puffers are your chronic bronchitis patients. They're going to be like a pink reddish tone. They're going to be bloated. They're going to be like puffy. Whereas your barrel chest COPD patients, those are going to be your blue or your, I'm sorry, that's your pink puffers. And then your blue bloaters is like your bronchitis. So they get this barrel chest. They're usually really small. And you'll see like their anatomy, they look like their chest is a barrel. It's like puffed out. So work of breathing, whenever we look, listen, feel, right? So we're looking for work of breathing. Do they have that tracheal tugging? Do they have intercostal retractions? Are they tripoding? Do they have any accessory muscle usage? If it's a kid, are they flaring their nostrils? Pursed lips is another big one for COPD. That's like them giving themselves an auto peep. So as they take a breath and breathe out, they have so much CO2 retention that they're trying to blow everything out of their lungs, but they can't because everything's constricted. So you'll see them like, they get like this pursed lip breathing. And then this is just referring to the 2 to 3 word dyspnea that we were talking about. So it doesn't have to be 2 to 3 word. It can be 1 word dyspnea. It can be 5 word dyspnea, but that's kind of how we refer to it whenever we're like trying to explain to somebody if they're having difficulty breathing or not.
And try not to have unnecessary conversations with these people if they're like that. Learn pertinent information, but you don't need to know their whole life story if they can only talk to you in 2 words, right? Ask them how long it's been going on. Ask them if they have a history of lung issues, but don't ask them about what they did in 2nd grade.
Yeah.
You know, they're having a hard time talking, so take that into account.
That's kind of where like we teach like open end questions. In those scenarios, we kind of ask more closed ended questions. So like yes or no, or thumbs up, thumbs down kind of thing, just because that's easier to, until you get their breathing better, that's going to be one of the better ways to communicate with your patient. So also part of our observation, we're going to look at their skin color, temperature, condition. Is it cyanotic? Is it pale? Is it clammy? Is it red, flushed? Is it hot to the touch, right? So pedal edema and sacral edema, what does that tell you? What does their ankle have to do with their lungs? Fluid buildup. So if they have edema and you're poking and you see like your fingers stay indented, sacral edema, they'll start to get edema right in this area. So that's not a common place for us to look. Some people forget about that, honestly, but whenever we start to get that fluid buildup, it's going to settle in the lowest parts. So you can see it right here. And then obviously the SpO2 less than 95%. I will say whenever you're doing an assessment, a physical assessment on a patient with difficulty breathing, and you look at their ankles and they got chicken legs like me, still poke on their legs because you're not always going to see the edema, but you can feel it a lot of the time. This is that barrel chest kind of thing that we're talking about. So is he altered? Cyanotic, neck and facial muscles. Is he straining to breathe? Is he working to breathe? They can still have chest pain and it not be a cardiac issue. It can be a pulmonary issue at this point. Abdominal muscles, numbness and tingling in hands and feet. This is like really, really common in your anxiety patients that are breathing really fast. They get carpal pedal spasms and their little hand will do this number. So they're breathing so fast that they start to clamp down on their hands. Any kind of lung sounds. So make sure you're assessing lung sounds with these patients before and after any kind of interventions that you decide to do. All right. So listen to bilateral lung sounds. What is that? What is bilateral? Both sides. Yeah, good. So the wheezing, that's that high pitch, like right? That's going to be in the bronchioles. So that's a lower airway issue, right? So we think upper airways from about this point up, lower airways is down. Sorry, Austin. All right. So take note whether this wheezing is inspiratory or expiratory or both. So whenever I say that, what I mean is like, are you hearing the wheeze whenever they take the breath in or when they let the breath out? So it can mean a difference in what's going on inside of their lungs, right? Crackles or rails, this is that bubbling. So their little raviolis are filling up with fluid. And it's indicative of pulmonary edema. So what is pulmonary edema? Fluid in the lungs. Good job. Which is usually caused by what? Huh? It can be drowning. CHF, congestive heart failure. They start to get that fluid back up in their body and in their lungs. And then your bronchi. So I remember this is still lower, but it's higher up in the lungs where the bronchi are. So you get bronchi in the bronchi. That's how I remember. Still lower airway thing, but it's still kind of higher up in those airways. So remember our bronchi, and then it's split off into our bronchioles, right? So it's that larger air passage. Usually caused by secretions. This is usually like where that pneumonia comes in. You'll hear bronchi, and it's like a big, deep, bubbly sound, like you guys heard in the video. Stridor, this is going to be our upper airway stuff. So whether it's a foreign body obstruction, whether it's swelling, there's something up here in the upper airway. And that's what causes this stridor. It's like that high pitch. You can usually hear it whenever you walk into the house. It's like, and then, drooling or whatever else is associated.
Knowing the difference in these lung sounds, I know I harp on National Registry. I'm going to keep doing it. Knowing the difference in these lung sounds and what they mean is important for your tests. So knowing that stridor's upper airway, knowing that wheezing's lower airway, knowing that like rails and crackles and all that stuff, just knowing kind of what they're associated with, how to treat them, and where they're located is pretty important going forward too.
Mm-hmm. Yeah, because if you hear like rails and you're giving albuterol, you might be solving some of their problem, but what do they really need if they have fluid in their lungs? They need CPAP. They need positive pressure, right? Because you want to force that fluid that's in those alveoli out. So as we move down our little sheets here, we're going to check our vitals. So obviously we're going to get our normal vitals, but things that may be associated with respiratory problems is decreased pulse rate, especially in kids. Kids, when they get hypoxic, their little heart rates like to drop. So there's a problem there and you need to solve their problem. Rate, rhythm, quality of breathing. We're going to count the respirations. We're going to take note whether it's regular or irregular. Their blood pressure could be high, could be low. So there's no like specific indication there. And then hypoxia is what? Low oxygen saturation? Good. What's a normal oxygen saturation for an adult? What's that? Above 95. Yeah. So whenever we start talking about like cardiac and stroke stuff, we want 95 to 99%, but normal is above 95. So whenever we're taking care of our patient, as we're going through our airway assessment, we get to A and say they're not breathing at all. We want to start bagging them immediately. We're not going to wait till we get down to lung sounds and all this stuff. As soon as you recognize like, hey, there's an airway problem here, you need to solve the problem. So it's either bagging them, giving them oxygen. Like we've been talking about, National Registry loves non-rebreathers. So if they have any kind of difficulty breathing, National Registry wants you to put a non-rebreather on that patient. We also have our nasal cannulas. Some people are on nasal cannulas all the time. They're prescribed. I'm sure you guys have seen either someone in your family or someone else. They walk around with their little bag of oxygen. So make sure you're taking note of that whenever you're doing like your history taking, like, hey, do you stay on oxygen all the time? Are you supposed to be on oxygen all the time? Because there's a lot of people that don't like to wear it. We're going to keep them in a position of comfort, usually for a difficulty breathing patient that's sitting up, right? So like that tripod position, they want to keep that weight off. And then if needed, you can administer CPAP as well. Does anybody remember the criteria for CPAP, for putting somebody on a CPAP? They have to be able to follow commands. They can be altered, but they just need to be able to follow commands. So if I looked at Chaz and said, hey, what year is it? And he said 1966. But I said, hey, give me a thumbs up. Cool. He's following commands. So he can be altered, but like if they're super altered, like unresponsive altered, we're not going to put it on them. So able to follow commands, the respiratory rate above what? 24? SpO2 less than 95, and accessory muscle usage. Okay. So our CPAP looks like this. I'm going to scoot Hal over here.
Also, be mindful whenever you're using this if their blood pressure is super low, because this can drive their blood pressure down, right?
Yeah. Why does it drive their blood pressure down? Does anybody know?
What is it doing inside your chest?
I'm going to tilt them this way so they can see them a little bit better.
So what's it doing inside your chest?
I heard pressure right here. Positive pressure is putting too much pressure in the chest, right? What else shares a spot with our lungs? Our heart. So whenever we're putting a lot of pressure inside of our chest, we're going to be putting pressure on a lot of those major arteries, and it's going to cause that blood pressure to go down, right? So whenever you're putting on CPAP, we're going to use it for like our pulmonary edema. Whenever they meet that criteria, you can put someone with a suspected PE on CPAP. So here's a mask. It's got this part right here. Make sure they can see. This can adjust up and down. Okay.
Kind of fit their face a little bit better.
This right here is called a PEEP valve. I'll show Austin real quick. So this right here is called the PEEP valve, and there's little numbers on it. So in most cases, when you start, you can turn this and it'll adjust at 5 to 10. Some of them go up to 15. You want to usually start at 5, unless they're like actively spitting out frothy edema. You're going to start at 10, but we're going to start at 5. So this is going to hook up to your oxygen. It goes 10 liters. It
This
tells
will
you right
drain
here.
your tank pretty quick. So
Yeah.
be mindful of that.
Yeah, it tells you right here how many liters per minute is going to go. These can change. Some of them just plug right into the wall, but this one specifically plugs into your oxygen tank. So this goes on here. If I'm going to be putting it on Hal, I'm going to talk him through it first, right? So I'm going to look at him and say, hey, buddy, you're not breathing very well. I have this mask. It's going to shove air into your face. It might be uncomfortable.
Has anybody ever seen anybody on a nasal cannula? Yeah. Could you hear that nasal cannula? Like just screaming air? No. We're going to hook this up real quick and understand why you need to talk people through this, because this sounds scary.
Oh, this
Excuse
one's
me.
empty. So
80. You go grab me an oxygen tank.
thank you. So whenever you turn this on, keep in mind that you're not going to be able to hear your patient talk very well. So put that over your mouth and try and.
Hello.
So imagine that with like in the background. You're not going to hear him very well. So that's where like the close end questions kind of come in. But as you're putting it on them, say, hey, this is going to be uncomfy. I don't strap it and click it and leave it right away. I hold it to their face, or I have them hold it to their face so they can kind of get used to it, because it's uncomfy. It kind of feels like if you've ever put your head out the window while you're driving or while someone else is driving, and you're trying to get that breath in because there's air. That's kind of what it feels like. But now they're suffocated because you're putting a mask on their face. So hold it there, have them take a couple deep breaths in, be like, hey, is that okay? Are you doing all right? If they're not doing all right, take it off, allow them to take a couple deep breaths and just walk them through it again, or have them hold it. And then from there, once they're comfortable, usually these masks fit their face okay. We have different sizes of masks. So as you're putting it on, there's a bunch of different ways for you to kind of adjust it. So it clips in on the side, and then there's two straps here that also like Velcro.
There's two straps on the top and bottom.
Yeah.
Whenever you adjust this thing, try to adjust it both straps at the same time, because whenever you put this on their face, if you just snatch on one strap, it's going to snatch this off to the side, right? So whenever you do it, try to adjust both of those straps at the same time. It's not going to be super comfy, okay? And they're not going to like it very much. But get them used to the airflow first, and then just kind of talk them through the uncomfiness of it, because this thing right here is just kind of like rubbery plastic, and it sits right here on your forehead the whole time, and so it's just big, bulky, and aggravating.
Another thing is the seal on these CPAP masks are way easier to get any seal than like our regular BBM masks. So that shouldn't be so much of it as a problem. So try and avoid, like, if you do have like a leak or something, just try to adjust it on their face a little bit, because usually they're a little bit better about getting that seal.
Turn her on.
So the way that these are, it's actually like a double layer. And I haven't noticed putting them on that much of a problem with bearded patients. If so, you can still try the lube thing. You can do the Tegaderm thing around their face. Don't go shaving their face, please. So these create, like, I don't know why every mask is not made like this, because it's awesome. But that's what it sounds like.
So now,
So that's on 10 here with a PEEP of 5. Yeah.
So now when I put this on my face,
Huh?
right?
Yeah.
You pretty much can't hear anything that I'm saying, right?
a lot of freaking wind. So be mindful of that. Another big thing to note about these: can you bag a patient while they're sitting up? Why not? Right? So if you have a pulmonary edema patient that has a lot of fluids in them, do you want to lay them flat? No. Cool thing about this is if you pull this off right here, this will hook directly into your BVMs. So if you have this on your patient and they go unresponsive in the middle of you doing this, but you still need to control their airway, you can leave this on their face because it's already got a good seal, and stick that BVM right here. Me and her's done it on overdoses before. Stick this BVM right here and start bagging them. Right? And you can do that while they're sitting up like this. You can just sit there and bag them while they're sitting up like this.
Yes. Yeah, they like to teach that you bag while they're laying flat. You can bag while they're laying flat, but like he said, if their lungs are filling up with fluids and you're laying them flat, you're causing more of a problem, right? So we like to keep them sitting up.
So
yeah.
Yep.
Yeah.
PEEP is 5.
So this one specifically says just 10 liters per minute here. But some of them have like this little like hook here, and it just hooks right into the hook. So you don't even have to adjust the flow. It's really dependent on what CPAP that you have. This one specifically is 10 liters per minute, but some of them are not like a specific liter per minute. So whatever the manufacturer's recommendations are, that's what you do. The biggest thing to remember, like test wise, is you start at a PEEP of 5. So what PEEP is is it's keeping that air in. So like as they try to breathe out, there's like a one-way valve there that's letting them only breathe out so much. And so it's keeping that air down in their lungs. Does that make sense?
And we're going to try to show that to y'all on Saturday with the cow lungs.
Yeah.
And so there's some pretty cool videos where you can watch people and they'll take the PEEP and essentially they're trying to blow their lungs up. But once you get all the recruitment of the little alveoli using these PEEP valves, you want to hold that, right? So that's what you're trying to do is open up their lungs and hold their lungs open. One big downfall to this as EMTs or advanced EMTs is what are you giving patients with this if you're trying to get fluid out of their lungs that y'all can give as long as they are administered or as long as they are prescribed it. Huh? Well,
You can give it with albuterol.
you
But another
can
big
hook this
one's
up to
nitro.
albuterol, but you can hook the albuterol up right here. But another big one is nitro. So because nitro is a vasodilator, it opens up all the vessels in your lungs and you can push fluid out of their lungs. The big problem is as advanced EMTs, you can do that. But every time you go to give them nitro, you have to take this off their face and give it to them and then stick this back on your face. And now you've lost all the recruitment values that you've worked by leaving this on their face.
Mm-hmm.
So that's the only downside. When you put this thing on, don't take it off because then you lose all the progress that you've worked trying to recruit their little lungs.
I will say that if they do go unresponsive and you're still trying to bag them, it's okay to take it off to insert like an adjunct or something like that.
That is terrible sounding.
Yeah, I know. I need some WD-40. All right, so inclusion, respiratory rate greater than 25 breaths per minute. I said 24. I apologize. SpO2 less than 94%. Retractions or accessory muscle use. They need to meet 2 of this criteria to put them on CPAP. Okay. Exclusion criteria. If they're too altered to follow commands, they don't get it. If they have any kind of chest trauma or suspected pneumothorax, hemothorax, don't give it. You're going to just increase the pressure in their chest and cause more problems. Okay, apnea, if they're not breathing at all, don't do it at all. Don't do it. Vomiting, GI bleed, that one's kind of common sense, right? Because if they're vomiting, you don't want to shove it back down into their airway. And then their blood pressure. So any kind of blood pressure under 100 millimeters of mercury, systolic, you don't want to put them on CPAP. Say that they need CPAP, but they they meet some of the exclusion criteria, we're going to bag them instead. Okay. So hypotension, it is a possibility that they develop a pneumothorax while you have them on CPAP. That is a possibility. Increased risk of aspiration, and then drying of corneas. So that air, you kind of get this little leak right here and it dries their eyeballs out. Okay. Our CPAPs, if you have it in your protocol to be able to give albuterol with it, there is a little hookup thing on the bottom. You can give albuterol while you're doing CPAP. So we talked about this. Explain the procedure to the patient. Start at 5 of PEEP. Those little PEEP valves, they change. So just whenever you start working somewhere, ours look like this, but I've seen them look different. So make sure you're putting hands on your equipment whenever you start learning how to do stuff. Reassess frequently. If they're unstable and you're putting them on CPAP, how often should you reassess your patient? 5 minutes, good. If there's no relief in a few minutes, so just kind of keep an eye on them, listen to their lung sounds, their oxygen saturation is not coming up, they're still really struggling, try to increase that PEEP. So I like to increase it by like 2.5 increments. So I go from 5 to 7.5 to like 8, 9, 10-ish. So just slowly move up as you're going. If they become altered or they stop breathing at all, you can take that mask and bag them. They show you taking it off and putting a whole new mask on it, but you can, just so you know, you can use that same mask.
The good thing about using the CPAP mask is it kind of frees hands because you can get that mask tightened down on their face and it holds a really good seal. So you're not sitting there trying to do the CE method and really like hold that mask. That CPAP mask kind of takes that out of the equation because you can get it sealed up on their face really well and then start bagging them with it.
Mm-hmm. So this is the only picture I could find of that pink puffer blue bloater thing. So here's your pink puffer, the one on the right. Barrel chest, he's pink because of CO2 retention. Chronic COPD here. This is chronic bronchitis. See how he's a little bit more bulky? He's a blue bloater. He's going to be blue, cyanotic, chronic bronchitis. So COPD, what is that? It is an umbrella term for a laundry list of other diseases. So chronic obstructive pulmonary disease, that's just an umbrella term for other things. So it covers that emphysema, that chronic bronchitis, those kinds of things. So overwhelming majority of cases are caused by cigarette smoking. Obviously, that's bad for your lungs, right? So bronchitis, if we break that word down, bronchi, our lung tubes, right? Itis is inflammation. So bronchitis. They also get this excess mucus that's produced during bronchitis. So that's causing what kind of lung sounds do you think? You could hear crackles with it. More rales, yeah. So rales, bronchi. Rales and crackles are the same thing. Bronchi and the bronchi. So emphysema, these walls break down, their little bronchi tubes get hard. You don't have as much recruitment in the alveoli because they're not able to expand because they get hard. So they have chronic, like breathing problems, CO2 retention. So here's our bronchitis. There's little mucus plugs in there. And then emphysema, this is like stuck here. It's not gonna expand like it's supposed to because it's just hardened. So people that have been dealing with this for a really long time, you'll see those anatomy changes, and then you'll really see them like do that pursed lip breathing because they're just used to trying to breathe all the time. And it's just normal for them most of the time. So asthma, this is another like bronchi problem, right? So those bronchi get inflamed. You start to hear that wheezing sound. What medication do you give for the wheezing sound? Albuterol. Good. And then we have pulmonary edema. Like y'all said earlier, it's a sign of like congestive heart failure. Your drownings can cause pulmonary edema. So this alveoli fills up with fluid, and that oxygen's not able to get down into the capillary bed where that oxygen exchange takes place. And so then you get hypoxic, right? So signs and symptoms of pulmonary edema, kind of least, what's the word I'm looking for? Like least initial to like the worst cases, right? So dyspnea, they're going to be short of breath. Dyspnea is difficulty breathing. Anxiety, anytime someone's oxygen saturations go lower, you're going to see anxiety. I would too, honestly, if I ever feel like I couldn't breathe. Pale and sweaty skin. What's another word for sweaty skin? Diaphoretic, good. Tachycardia is what? Fast heart rate. Hypertension is what? High blood pressure, good job. Irregular respirations, hypoxia. We know what hypoxia is. This frothy sputum is a big one. So whenever, you're not going to see it every time somebody has pulmonary edema, but if it is to that point where you walk in and they're coughing and it looks like they're spitting up like strawberry milkshake or like white foamy stuff, it's time to step in. That's a problem. You better pray. Yeah. Hey, Jesus, me again. Crackles and rales, that's that fluid in the lower, the little Rice Krispies. Sometimes you'll hear a wheeze. I was taught with cardiac problems, you're going to hear an inspiratory wheeze. Now, I'm not saying that every just inspiratory wheeze that you hear is cardiac, but that could kind of indicate like, hey, this is a cardiac in nature. And then if you hear like a gurgling, but there's like not really anything in their mouth and you're hearing like that, that's also a problem. So just too much fluid.
Big problem.
Yeah. So our treatment for pulmonary edema, we're going to give oxygen, preferably CPAP if they meet the criteria. If you can keep them sitting up, that's ideal. A good history taking assessment for somebody that has like problems with their fluid in their lungs is asking them if they have to sleep with like a bunch of pillows at night or if they have to sleep in like sitting up in a recliner, because as they sleep and they can't lay back flat, they're going to feel like they're drowning. So sometimes if you ask them like, hey, whenever you sleep, like, do you have to sit up? And a lot of times they'll tell you yes, if this has been like a developing problem for a while. You know, I'm not 100% sure. I don't think so.
I wouldn't see any correlation between the two.
Maybe, but
But I know like any sort of fluid imbalances, like kidney failure patients that do dialysis and stuff like that. If they don't go to dialysis to get the extra fluid pulled off of them, a lot of times they can have the fluid build up and back up. Congestive heart failure patients, drowning patients. Like she was saying, that pink frothy sputum. Another big thing to worry about is what they call flash pulmonary edema. If you ever get a chance to YouTube what that looks like, it is very, very scary if you see it in front of your face, because they are very close to death.
Yeah. If you ever get called out to like a difficulty in breathing and you walk in and they're tripoding and they're just foam, like that's a bad day. All right, so pneumonia, this one, pretty common, especially like in our older folks. They're pretty susceptible to it. If they have chronic problems, they are more susceptible to things like pneumonia. So infection, it can be just on one side. It can be both sides. Usually whenever we think infection and we think like a productive cough, like they're coughing up like green or yellow sputum, like they're coughing that mucus up. Sometimes they don't have to be coughing it up to have pneumonia, but that could be like one of those assessment things, like ask them, hey, have you been coughing up anything? What color is it? Is it green? Is it white? So yeah, it can be from bacteria, virus, or fungi.
Fungi.
So yeah.
Fungus among us.
So yeah, there's fungus among us. So signs and symptoms, we got that shortness of breath with or without exertion. Another thing I've noticed, if they go to take a deep breath in, they just start coughing, like they just can't take that deep breath in. Fever and chills, so think of it as an infection, right? So how does our body respond to an infection? So we get fever, chills, high temperature, headache, cool pale or hot pale diaphoretic. They could be flushed. There's a lot of different signs. So big thing here, we're going to listen to lung sounds. What kind of lung sounds are we going to hear with pneumonia? Bronchi. Bronchi and the bronchi. So all that mucus. Confusion. I can spell, I swear.
Pneumonia.
Confusion. That's not a new thing. That's just a typo. All right. So you can consider CPAP. Another thing to be careful with giving CPAP to a pneumonia patient. If their infection has spread to where they're in the point of like sepsis, their blood pressure is going to be too low to put them on CPAP. So just keep that in mind. We're going to treat that hypoxia though. Remember, any difficulty breathing. If I want to put on an on breather, what liters per minute am I going to be putting that on? 12 to 15. Good job. In extreme cases, you may have to bag for them. So this is like treat the symptoms kind of thing, right? So don't be putting a nasal cannula on somebody that's breathing 2 times a minute. All right, so our spontaneous pneumothorax. This can happen. It's like not trauma related. It's very common. It's more common in certain individuals. So somebody that has like a chronic COPD problem, they can get a spontaneous pneumothorax, or really tall, skinny males. They're just like at a higher risk to get the spontaneous pneumothorax. So what kind of signs and symptoms do you think you guys are going to hear or see with a spontaneous pneumo? Trouble breathing, good. You could, yeah. Like abnormal chest rise and fall. What'd you say? Absence of lung sounds or diminished lung sounds on one side, unilateral. Okay, what else about vital signs wise? SpO2 goes down, respiratory rate usually goes up because they're trying to compensate, right? They're trying to make up for that extra lung they're missing. If you are suspicious of a pneumothorax, contact ALS or take them to the closest appropriate facility. So there's interventions that need to be done that y'all can't do. Get this fancy little needle and we shove it in their chest. But while you're waiting to either get ALS there or take them to the closest facility, give them oxygen.
Again, be careful with bagging these folks. Don't put them on CPAP because you can worsen that pneumo. So just be mindful of that stuff. I'm not telling you if they stop breathing, don't bag them because they need that. But just be mindful of that and be careful of that because it can make that pneumo worse.
Yeah. And then our CPAP contraindicated, right? Like Chaz just said. There's a tall, thin guy. Thanks, Google. So we went over this tachypnea, like a fast respiratory rate, hypoxia, decreased or absent lung sounds. Another big one is JVD. What is JVD? Jugular vein distension. So there's too much pressure in that chest and it's going to start to bulge out here. The hypotension in JVD, this is a late sign of a pneumothorax. So this is something that if you're seeing this, like they need intervention very quickly. Especially like with the tracheal deviation, that's super, super late sign. Like we teach it and we say to look for it and you should, but just keep in mind that don't be like, oh, they don't have tracheal deviation, so they don't have a collapse then. That's not the case. All right, pulmonary embolism. These are super fun. These are like the calls that sneak up on you because you're like, oh, they have difficulty in breathing, but their pulse ox is good, but they're really anxious. And then you get them to the hospital and they're like, PE. So there's a ton of signs for a PE. It's always something to keep on your radar whenever you're talking about difficulty breathing patients, chest pain patients. This is always something to be considerate of.
Even
Obviously,
in young patients.
Yeah, especially young patients. Those are the ones that bite you in the butt.
Yeah, me and Becca had a 30-year-old male that died on us because of a PE that called for an asthma attack. So even in these young patients, be mindful that there's still a possibility that they can have these.
Mm-hmm. I'd say the most like off the wall complaint that I've had that they're like, oh, it's a PE, is actually like anxiety. Like they called, it was like a 28-year-old female. She called for anxiety. And most people would walk in and be like, oh my goodness, 28-year-old with anxiety again. But she had a PE, and after further closer evaluation and like an assessment on her, I was like, oh crap, this is probably a PE. But a lot of providers don't do that because they kind of get in this rut of like just anxiety. So make sure you keep these things on your radar because it can come back and bite you in the butt. So it's a blood clot in the lung, pulmonary embolism. That blood clot can come from like their leg if they have like any kind of sedentary lifestyle where they're not moving around a lot, if they're bedbound for whatever reason, long plane rides, long trips where they don't get up and walk around. So any kind of sitting down for a long time, higher risk. Normally, if someone's having like that difficulty breathing and I'm trying to kind of work through this, I'm going to look at their legs. I'm going to feel their legs. Hey, if you have any leg pain, do you have redness, you have swelling, do you have any diminished sensation or pulses like in that leg? If you do. Active cancer patients also have a higher risk of this. Another thing to keep in mind is like your younger females or even older females, if they've been on birth control for a long time, they're at higher risk for a PE. And then any kind of limb immobilization from casting, obviously. I thought this picture was cool. A nice little blood clot shaped like the bronchioles. I pulled it out of someone's lung. Another kind of cool thing about PEs, not cool, but cool. You can get something called a saddle PE where it sits right, it's like a saddle embolus, which sits like right on your pulmonary vein and artery. And your patient will turn purple from their nipple lines up. So everything else will be like a pale color. And then from this line, it's like someone drew a line right up here, purple. So kind of cool. Usually they're dead by that point.
And there ain't no getting them back.
And there's not getting them back. Yeah, they're donezo. Signs and symptoms of the PE, like we said, this can have a broad range of signs and symptoms. We're going to be treating those signs and symptoms appropriately, but here's some of the major ones. Swelling in the legs, lightheadedness, breathing fast heart rate is like one of the number one vital signs that you'll see with a PE is tachycardia. Coughing, if they're coughing up any kind of like frothy pink sputum, that's also a problem because that could be, a CHF exacerbation, or it could be something like this. What does it mean by pleuritic chest pain? Yeah, so you have your pleural lining. So usually it's like a pinpoint pain, and it's like in their lungs area, and they can tell you right where it is. Epiglottitis. We talked about this a little bit at the beginning of class. Does anybody remember like the one specific little buzzer word that you should have for epiglottitis if it's a test question? Drooling. Yeah. So this is common in kids, especially kids that haven't been vaccinated. So if we break down this word, what does epiglottitis mean? Good. Yeah. Epiglottis, the little flappy thing in our throat, and it's swollen and inflamed, right? So severe cases can cause airway obstruction. There's also a pretty like prominent sign that you'll see, especially like with kids. Kids will do that little tripod position. They'll lean forward, their mouths will be open, and they'll be drooling. And then at that point, like, what are you going to do for them? Does anybody have any ideas? Suction. What else? If they need it, yeah, if they're not breathing, you can ventilate for them. So you want to do oxygen administration, right, if they're hypoxic. But one big thing with epiglottitis is you don't want to rile them up anymore. So try and avoid the lights and sirens, trying to avoid a lot of external stimuli. If you can have mom like do blow-by oxygen, that's one of the best things because you're not getting them worked up for more swelling to happen. So here's a happy, healthy epiglottis. Happy? Not happy. So it's swollen. What kind of sounds do you think you might hear with epiglottis if it's an upper airway problem? Strider, good job. So sore throat, tripod position, they kind of get this like open mouth. They like to lean forward. Sometimes they stick their tongue out, but that drooling should really be that buzzword whenever we get into test taking when they're talking about this. This is not super common, especially if they're vaccinated, but still keep it on your radar. Keep them calm. Don't go digging around in their throat, please. I think this is a video. Yes. More kiddo problems. Okay. Don't want to play? Oh, let me try and click on it. All right, so that's croup. So they very distinctive seal. Are you here? You just pull your gun? Oh, I just watch her like pluck it right out of her. So croup, one big buzzword whenever you're taking the National Registry test, the seal-like barking cough. That's what you're going to hear. You should think croup, and that's what it sounds like. Now it's not going on.
I'll click it.
All right. So loud barking cough, they get that hoarse voice. It's usually right in this area. There's a really long word for it, and I can never remember. It's like laryngotracheobronchiolitis is the like medical term for croup. Super long word. Croup is what it is. If they're hypoxic, we're going to give them oxygen. You're going to hear that inspiratory stridor. If you guys were paying attention to the kiddo's chest while during that video, you see that like intercostal retraction. You see a little bit of like retraction up here too. So difficulty breathing, right? Your treatment for croup, consider ALS. Obviously, if they're hypoxic and it's profound, you're going to treat for hypoxia and then allow the patient to remain in a position of comfort. A lot of times that's like with mom being right there, right? Bronchiolitis. So this is a, uh-oh. That's my least favorite sound in the world right now.
Transfer.
Yeah. So bronchiolitis, this is the way it was explained to me in paramedic school, which they didn't really talk about it too much in your guys' book or the PowerPoints, was bronchiolitis is mostly like what kids are diagnosed with before they're officially diagnosed with asthma. So bronchiolitis, if we break that word down, what does it mean? Swelling of the bronchioles, right? So what kind of lung sounds are you going to hear with swelling of the bronchioles? Wheezing. So wheezing, those tubes get constricted and they whistle. Like taking a balloon, and everyone's done that with a balloon, right? Where it's like, that's what your bronchioles are doing. So the most common cause is RSV. If they have like recurrent episodes of this, they get diagnosed with it usually about the age of 3. And then from there, if they still have recurrent and it's chronic to them at that point, it's now called asthma. But usually, like the little kiddos, they'll start saying that they just have bronchiolitis, which is like asthma. They can have like their own prescribed albuterol that you guys can assist them with. If you get there and mom has a little nebulizer with the dinosaur mask, you can help them. So that's what their little bronchi look like. They get sad and squishy. So associated with other cold-like symptoms, runny nose, fever. Usually if you have like a household with a bunch of little kids in it, they like to share their little sicknesses. So that's usually a like symptom or assessment that you can do, like asking mom, like, hey, do they go to daycare? They can be exposed to it there, like a lot of the RSV stuff. Fever, usually it progresses and then it just gets worse, and that's usually about the time that they call us. So make sure you're checking temperatures on these kids, oxygen saturations, all that fun stuff. If they stop breathing or they're not breathing adequately, we're going to ventilate for them. You can try and use that little bulb syringe that we keep one in our OB kit and one in our PD bag. If you help clear out that mucus, that can really help too, because kids like to breathe out of what part of their face? Nose. Yeah. They're obligate nose breathers. All right, cystic fibrosis. This isn't super common. I think in the 10 years I've been doing this, I've dealt with one patient that's had it. It's very sad. So it's a genetic disorder. They get this thick, sticky mucus, accumulates in their lungs, can accumulate in their digestive tract. Usually, if you're going on an adult, they know that they have it by the time they're an adult. But with the kiddos, sometimes it's not caught right away. Actually, one of the first signs that the parents notice before getting diagnosed with cystic fibrosis is they'll be like kissing on their baby and they taste salty. And then they'll be having like GI problems, breathing problems, and then that's when they get diagnosed with cystic fibrosis. I think like the average life expectancy of somebody with cystic fibrosis is like the early 30s. So this is like they deal with it their whole life. Their immune systems are usually compromised because they're always dealing with lung infections. So a very sad thing. That's what baby poop looks like with cystic fibrosis. It's very mucousy. Yeah. So coughing with large amounts of mucus, they just have an excess amount of mucus in their body all the time. Fatigue, frequent pneumonia, abdominal pain and distension because it is affecting their GI tract. Hemoptysis is what? So break the word down. What's hemo? Blood. What's optysis? Optysis. Coughing. So coughing up blood. Hemoptysis. Nausea, weight loss. The treatment, they get these little vests, and these vests like beat the crap out of them. and it loosens up that mucus. And then a lot of times they're on a laundry list of like medications that help thin that mucus and that helps them like clear out their airways. So the cystic fibrosis patient that I dealt with, he was very, very knowledgeable about his situation. He knew he had pneumonia before we even got there. His house was like immaculately clean, and he had like all of his medication sitting out for us to look down. He knew that, like, hey, I have pneumonia. I did my part of it. Like, I need to go to the ER now. But family, your patient, they're going to be very knowledgeable about this. By the time they're diagnosed, parents are going to be educated. So don't be hesitant to ask them. Viral respiratory infections. I'm sure everybody in this room has had one at some point. We had one like 3 weeks ago. So very common. You get the sore throat, scratchy throat, mucus, coughing up mucus. It can spread. It can go down into your lungs. You can get infections from it, like sinus infections, those kinds of things. This productive cough, another thing, asking them what color their mucus is that they're coughing up.
7 o'clock.
Oh, it is 7 o'clock. I just looked at my watch too. So for your viral respiratory, make sure you're treating hypoxia if it's present. Sometimes they need bronchodilators if they have other problems like asthma and then they get like a viral infection. They might need to use their bronchodilators more, their little inhaler. One thing to always keep in mind is, like, if somebody does have an inhaler that they use, ask them how many times they used it that day and what is normal for them using it. So if someone only ever needs it once a day and they've used it 10 times today, that kind of indicates that there's something else going on, right? Now, the albuterol inhaler. So you guys have your little med cards. So it's a bronchodilator. What does that mean? Opens up the bronchioles, right? Bonus points. Does anybody know what receptors albuterol works on? I almost said asthma. Beta 2. Good job. How do we know beta 2 has to do with the lungs? Yeah, you have 2 lungs. Beta 1 is 1, right? So 1 heart. You have 1 heart, 2 lungs. What are indications for albuterol? Respiratory distress, wheezing. Well, there's one more specifically to you guys as an EMT basic. It has to be prescribed to them. Yeah. So you can use it for allergic reactions as well. Whale. I don't know how I just turned like Washington, but I did. So allergic reactions, you can get that wheezing too. So don't hesitate to use it. Contraindications. Does anybody have any idea? Not prescribed to the patient. That's it. So whenever you start looking at like protocols and drug sheets and stuff, you might see other few like contraindications on here. So like if they're not able to use it, if they've already taken the maximum prescribed dose, and we'll talk about that a little bit. You also want to look at the heart rate, right? Because albuterol does what to the heart rate? Increases it. Why? Yeah, is a sympathomimetic. Good. So not being prescribed to the patient, contraindicated. Don't grab grandma's inhaler and give it to the niece or whatever. What's your dose? Yep. How often? I think your book says 30 minutes. 2 puffs. Yeah. 1 to 2 puffs. Oh, your guys' book's a little bit different. Yeah. Okay, so 1 to 2 puffs, 2 to 4 puffs. So just don't give them 10 puffs. Beta 2 agonist. So we also have this little spacer thing that you might see. That's really helpful in kids, making sure that they're getting the full dose. Usually prescribed to them if they have conditions that cause bronchoconstriction. So whenever we assist with an inhaler, one thing, like you get there and they're like, I hit this thing 5 times. A big thing to look at is right here on the back of the inhaler. If anybody has one, I'm sure you're familiar. It tells you how many doses are left in there. So there's been plenty of times that we show up and they're like, my inhaler is just not working, and it says 0. That's probably why. Another thing is people get really anxious when they get short of breath. So one thing you might see is like they've tried like using it a lot, but they're just not getting it where it needs to go. So as we're talking patients through, you can look at the inside of their mouth and they get like this white film when they've used their inhaler a lot, and then they're really anxious. So I've had them before where they like go wash, like take a cup of water and wash their mouth out. Mouth gets dry. So as you're like walking them through taking their own inhaler, you're going to have them take a deep breath out. And then as they breathe in, you're going to squeeze it so they get it where it needs to go, right? Because their little beta 2 receptors are in our lungs. So if they're not breathing it in all the way, it's not going to get where it needs to go. All right. So some patients might also have a nebulizer. We touched on this a little bit. It looks like our nebulizer mask that we have, but they get this like fancy little machine. So whenever we're talking about nebulizing something, it's pushing air through a liquid and making it like a aerosolized form so that patient can breathe it in. So some of them look like this. They get this little tail off of it. You can assist the patient with their medication if it is an inhaler. And that's it. That was kind of a long one, but not so bad. So whenever we start doing on Saturday, we're going to do, so on Saturday, we're going to do scenarios. So a lot of scenarios are going to be respiratory problems. And hopefully, if I can get it working tomorrow, Hal's going to have lung sounds. So I want you guys to be able to listen to lung sounds. I'm going to give Hal a certain lung sound, and then you tell me what you're listening for. Go over your medications that you're going to be giving to respiratory distress patients. And then we're going to be going over those medical sheets. And, well, we'll just go over medical sheets on Saturday most likely. So bring those with you. All right. What questions do you guys have? Any questions about your test that you took today? No? Okay. All right. I'm not seeing anything in the chat from Austin. Dang, that's 2 days I got you guys out early. So that's pretty good. I don't think I have anything else for y'all. So I have this one.
I found some on Amazon.
Oh yeah. Is it the one with all the different ones?
I told my wife.
Oh yeah.
That's for kids.
Ideal body weights.
Yeah, ideal body weights. The rule of 9.
Mm-hmm.
Respiratory sheets.
No.
Oh,
And it
see,
comes
that's-
with the-
yeah.
Calvin has that one. Awesome. Yeah, it's got like everything. It's got stroke assessments. It's got GCS. It's
Probably,
got
I
like
hadn't
criteria
looked.
for sepsis. Yeah, yeah. Calvin carries that one around. So the ones I carry is the. Oh yeah. I hate the rule of 9s. I hate calculating them, so I just keep this. And then here's like the fluid.
Y'all bring your
administration
skill
dose for that.
sheets on Saturday.
I told him.
Make sure you bring those. Right? I'm just gonna say it again. That way, if anybody forgets it, then you get
This
10
is
laps
called
around the
hand
station.
heavy, so it tells you the ideal
But
body
no,
weight for certain ages.
and then
the
make sure you
medication
know what days
dosages.
you're
Just
riding.
'cause, like, I'm
If
the
you
only
have
25-year-old,
any
I'm gonna be
issues
like,
on the days that you're
so
riding,
this helps.
let me know
He's
ahead of
also already
time.
memorized
That
it.
way
This
we can
guy
try to get you
taught
plugged in
his
somewhere else.
6-year-old how to run a code by this method.
And
so
like I
it's,
said
really
before, if y'all
easy.
want
Yeah.
extra rides, just let me
Um,
know. I would like to try to get everybody
This is
through.
our RSI
And then all of May is
checklist.
pretty much
So if we're
free.
gonna
So if y'all
put
decide that
someone
you
down
want to
and
ride
innovate
some
them,
of May
this
or
is
whatever,
specific
just
to Lander
let us
County.
know and we can work
This is
some
our
stuff in.
EKG badge. So
So-
this just helps you read an EKG. Gives you measurements. This tells you your isoelectric line. This
CJ, you can
vitals
kill the
for
recording
kids,
if you hadn't already.
weights for kids.